Hello everyone, I am Dr. Snehlata Verma, Reader, School of Dental Sciences, BBD University. In today's lecture, we are going to discuss about the interceptive orthodontics. As we know, orthodontics is the branch of dentistry that deals with the correction of malocclusion. So, orthodontics can be defined as the study of the relationship of the teeth to the development of the face and the correction of arrested and perverted development. Various disciplines of the orthodontics include preventive, interceptive, corrective, and surgical orthodontics. So, in the preventive orthodontics, we include the procedures which are undertaken prior to the onset of a malocclusion in anticipation of a developing malocclusion. And it is also called as a primary prevention. Whereas in interceptive orthodontics, the procedures are undertaken at an early stage of malocclusion to eliminate or reduce the severity of that developing malocclusion. So it includes the secondary preventive measures. And some preventive measures in the preventive and interceptive overlap to each other. Wherein corrective orthodontics, here the malocclusion has been fully established and we have to take the procedures to correct that fully established malocclusion. So corrective orthodontics recognizes the existence of a malocclusion and the need for employing certain technical procedures to reduce or eliminate the problem and the attendant sequelae. The procedures employed in this corrective malocclusion may be mechanical, functional, or surgical. Whereas the surgical procedures are undertaken in conjunction with or as an adjunct to the orthodontic treatment depending on the severity of malocclusion. So interceptive orthodontics can be defined as that phase of science and art of orthodontics employed to recognize and eliminate potential irregularities and malpositions in the dentofacial complex. Corrective measures may be necessary to prevent a potential irregularity from progressing into a more severe malocclusion. This is the point taken into the consideration. It is necessary to prevent a potential irregularities from progressing into a more severe malocclusion. So there are various interceptive measures that can be undertaken for the interception of the malocclusion. That includes correction of anterior and posterior crossbites, and second one, the removal of soft or hard tissue impediments to path of the eruption, or interception of developing skeletal malocclusions, then elimination of certain deleterious oral habits, then few muscle exercises to improve the functioning of the oral musculature, space gaining procedures, and finally the serial extraction procedures. In this video lecture, we will talk about the first three measures, and the rest of the measures will be taken in the another lectures. So coming to the correction of anterior and posterior crossbites. Here, the anterior crossbites may be skeletal or dental in nature. Skeletal crossbites may be because of maxillary deficiency or the mandibular excess, or the problem may be because of the combination of both these. Whereas dental crossbites arises due to presence of a supernumerary teeth, over retained primary incisors, or maybe due to trauma to the developing tooth birth that deflects the developing permanent tooth in a more lingual position. Developing crossbite can be corrected with the help of tongue blade therapy. In this, the tongue blades are used over the mandibular incisor margin that serve as a fulcrum, and the force is exerted over the developing permanent maxillary incisors. Here we can see here the permanent erupting permanent incisor is in somewhat lingual to the labial mandibular incisor, whereas it has to be in labial position to the mandibular incisors. And with the use of this tongue blade for 1 to 2 hours per day for 10 to 14 days, this developing and erupting permanent incisor can be placed into the proper labial position. This picture depicts the corrected position of the maxillary incisor. Next appliance we can use is the jet spring or double cantilever spring appliance. That is a removable appliance with the help of this removable plate incorporating a jet spring. We can also push the lingually positioned incisors to labial direction. And if there is a deep bite plate can be given, and posterior occlusal plane will help to disocclude the incisors so that it can be pushed forward in a lingual direction. 1.5 to 2 millimeter activation of this spring will produce 1 millimeter of tooth movement in a month. And after correction of the crossbite, only 2 months retention with passive appliance will be sufficient to maintain it in its normal position. Among the fixed appliances for the correction of this crossbite, we have a whip spring appliance that uses a 36 ml lingual arch with a 22 gauge finger spring made up of 22 gauge wire. So the spring is here, it is shouldered to the molar band, the thicker wire, and then the wire spring is shouldered to this thicker wire to the opposite side, and it will give a labial thrust to the developing incisor which is in crossbite. An activation of approximately 3 millimeter will produce 1 millimeter of tooth movement in a month. 2-4 appliance can also be used. It is a 2 molar bands which are and 4 incisors are bracketed, and the wire is inserted which has a certain extra length, and it is a choice of appliance for mixed dentition patients with crowding and rotations. Posterior crossbite occurs in patients with prolonged sucking habits that will create the V-shaped narrow maxilla, and the posterior segment of the maxillary dentition will come in crossbite in relation to the mandibular arch. Here we can appreciate the posterior crossbite of the molars, and here whole of the posterior segment is in crossbite relation. The problem can be due to the narrow maxilla, that is the skeletal dimension, or it may be dental due to the lingual tipping of the maxillary teeth. This type of posterior crossbite can be corrected based on their etiology by 3 approaches, which are equilibrium to eliminate the mandibular shift. We can expand the constricted maxillary arch to get a correction of a posterior crossbite, or the unilateral repositioning of the tooth which is in crossbite relationship. If the problem seems to due to the occlusal interference caused by primary canine and molars, the reduction of this primary teeth will lead to the correction of the crossbite. In case of constricted maxillary arches, we can expand the arch with the W arch or quad helix appliance. The W arch appliance is made with the 36 gauge stainless steel wire which are soldered to the molar bands. It delivers the proper force level when opened 4 to 6 millimeter wider than their passive width. So this arch expansion of constricted maxilla is a method of gaining space. The correction of transverse maxillary deficiency can be an important component of an orthodontic treatment plan, and the expansion of the palate was first achieved by Emerson C. Engel in 1860s. Ever since, numerous expansion appliances have been described with various force levels and duration of treatment. Expansion can be classified as dentoalveolar expansion or the skeletal expansion. Can also be broadly said as slow expansion or the rapid expansion. Slow expansion, which also termed as a dentoalveolar expansion. However, there is some amount of skeletal expansion is also been observed, and it is associated with a more physiologic adjustment to the maxillary expansion. It produces greater stability and less relapse potential than in the rapid maxillary expansion procedures. The force generated by slow maxillary expansion procedures are much more less, that is 2 to 4 pounds in comparison to the force generated in rapid expansion procedures, which are around 10 to 20 pounds. In this procedure, the expansion rate is slow, that is 0.5 to 1 millimeter per week. And this should always be slow because the normal width of the PDL is approximately 0.25 millimeter. And for orthodontic tooth movement to take place, an expansion device should not be activated more than 0.25 millimeter at a time. Hence, the screw that are used in this procedure for making the appliance, it is a 360-degree rotation of this screw will separate two halves of expansion appliance by 1 millimeter. And the activation schedule states that slow expansion appliance should be have a 1/4 turn per week, that is 8 turns a month in total. If we talk about the indications and contraindications of slow expansion, the slow expansion will be indicated in cases where the premolar basal arch width will be more than premolar diameter. And this can be ascertained by the Ashley-Ho model analysis. The one more thing, the slow expansion can be assumed at any age. Contraindications for this will be if the teeth are already in the buccal and labial inclination, if there is a bone loss on buccal aspect of teeth, or if there is a excess mandibular intercanine width. That will be a contraindications for approaching for slow maxillary expansion. Appliances which can be used for slow expansion are among the removable, there's a coffin spring or expansion screws, which we talked about. In the fixed, W arch, quad helix, night-eye arch wire, and among the functional appliances, various appliances which can produce both the active and passive expansion of the dental arches. If we talk about the quad helix, it is the more flexible appliance than the W arch. It is made with 38 gauge wire, and here there is a wider range of action due to extra wire incorporated in form of these helices. The expansion rate will be 2 millimeter per month, and the treatment phase will be about 2 to 3 months to expand the arches, and the retention phase will also include about 3 months of time. The third approach was for this expansion was the unilateral positioning of teeth. If there is a unilateral maxillary constriction of the upper arch. Coffin spring can also give the slow maxillary expansion. It was introduced by Walter Coffin and made up of 1.2 millimeter SS wire, and as it was introduced by the Walter Coffins, it takes the name of coffin spring, and it gives the slow dentoalveolar expansion. It has an omega shaped wire here in between, and that is embedded in the acrylic on both the sides. The spring is activated by pulling the two sides apart manually 1 to 2 millimeter per week. From here, these two sides were kept apart to activate the appliance, or it can be used. It can be activated by using the 3-prong plier. This is expansion screws, which we talked about, the pitch of the screw, and the activation schedule. This is a very small metallic appliance which may be designed to move a single tooth or a group of tooth. The screw as a source of force together with the acrylic segment of the plate affect the teeth and the alveolar process. Here, the acrylic plate is split in between, and when the screw is opened, 1/4 turn, 2 turn per week, it will expand the teeth in a label direction. Heavy force from a jack screw device is needed only when the mid-palatal suture has become significantly interdigitated during adolescence. Then after slow maxillary expansion, we have another maneuver which is known as rapid maxillary expansion. Bilateral skeletal crossbites with a deep palate and narrow maxilla can be treated by the rapid maxillary expansion, where the palatal suture is splitted in between. Because the problem is skeletal, in skeletal problems, we have to split the palatal suture to get the space and widen up the maxilla. Here the activation schedule is somewhat faster. The screw will be activated 0.5 to 1 millimeter per day, and force level can be up to 10 to 20 pounds, and it produces expansion in a very fast manner in 3 to 4 weeks. Indications of RME includes posterior crossbite, class 2 malocclusion with a narrow maxilla, cleft palate patients where again there is a presence of narrow maxilla which has to be expanded. During the face mask therapy in class 3 patients, before protracting the maxilla, we used to open up the mid-palatal suture that will facilitate the protraction of the maxillary segment forward. Some medical indications will include nasal stenosis, septal deformities, recurrent ear and nasal infection, allergic rhinitis. Contraindications of RME will be in cases of single tooth crossbite that can be corrected by the slow maxillary expansion. In uncooperative patients, this procedure cannot be used. After ossification of mid-palatal suture, unless it is accompanied by adjunctive surgical procedures, that is, after growth has been completed and the suture has been closed, the RME should not be attempted. RME should be attempted only in the growing patients. Skeletal asymmetry of maxilla and mandible, and adult cases with severe anteroposterior skeletal discrepancies. Single tooth crossbite can also be corrected by the cross elastics. Here, 3 by 16 inch lattice elastic generates about the 170 gram of force, which will lead to the fasciolingual movement and correct the crossbite. Here, if there is only single tooth in crossbite, so no expansion of the whole of the arch is required. Here we can see the maxillary molar is at fault, and in the crossbite relationship, this can also be corrected by the use of elastics. Here both the molars are banded, and a reciprocal anchorage is used to correct the crossbite of this particular molar. But this procedure should be used in caution with children where increased facial height is there, because due to uprighting of this maxillary molar, there will be some increase in the vertical relationship of increase in the vertical anterior facial height. Next thing that has to be taken into consideration during the interceptive procedure, if there is a presence of anterior diastema, but etiology of this may be abnormal frenal attachment, lack of space for maxillary lateral incisors, and supernumerary teeth present between the maxillary center incisors. So in case of abnormal frenal attachment, Frenum can be clipped in conjunction with removable appliance during mixed dentition phase itself. And removal appliances include finger spring appliance that small but anesthetic diastema can be closed with this and early mixed dentition. Among the fixed one, both the center incisors can be banded or bonded, and the two tubes are adhered that can be 032 or 036 in size, and small round wire of the same size is inserted. And here again, the use of a reciprocal anchorage for the correction for the closure of the diastema can be used. One thing should be remembered during this closure of diastema, that we have to rule out the etiology if the diastema is due to the ugly duckling stage. That is also occur in the mixed dentition stage during the erupting due to the erupting canine, and that diastema should be ruled out, should be taken away from the other etiologic factor, as I mentioned, that is supernumerary teeth or frenum. Diastema appearing due to ugly duckling stage should not be attempted at that phase. The diastema should be closed then after only the eruption of the complete eruption of canine only. Coming to the interception of developing malocclusions. Among that, developing class 3 malocclusion should be attempted to correct as soon as it has been seen. It results as a mandibular prognathism, maxillary retrognathism, or combination of both. So in this phase, chin cup with headgear helps in restriction of mandibular growth, and while the other functional appliance, that is Frankel regulator 3, can be used in cases of maxillary deficiency. The goals of this early interception will include to prevent the progressive, irreversible soft tissue or bony changes, to improve the skeletal discrepancies and provide a more favorable environment for the future growth, to improve the occlusal function, and to simplify the phase 2 comprehensive treatment. Early treatment may eliminate the necessity for the orthodontic surgery as well. Turpin developed positive and negative factors for deciding when to intercept or developing class 3 malocclusions. For interception, the positive factors, if there are a good facial aesthetics, mild skeletal disharmony, no familial prognathism, or symmetric condylar growth, growing patients with a good cooperation. In those cases, the interception of developing malocclusion should be aimed out. Whereas the severe skeletal disharmony, poor facial aesthetics, asymmetric condylar growth, or the completion of the growth, they will contraindicate the interception of that class 3 malocclusion. So the early treatment is considered for patients with the positive factors only. So skeletal anterior crossbite can be corrected with the help of face mask and the chin cup. Face mask can be given in actual deficiency of maxilla to mesialize the maxilla using a protraction face mask, or that is where we have different type of face masks, petted face mask, Delaire face mask. Anyone can be given for the correction of this skeletal class 3 malocclusion. In cases where the mandible is at fault and the class 3 malocclusion and anterior crossbite is due to the mandibular prognathism, in the interceptive procedures, we can use the chin cup to redirect the growth of the mandible. The chin cup will rotate the mandible downward and backward direction and will reduce the severity of developing class 3 malocclusion. In relative chin cup therapy, as I said, is used in relatively normal maxilla with protrusive mandible, provides growth inhibition or redirection and posterior positioning of the mandible. But Till date, there is no agreement in literature as to whether chin cup may or may not inhibit the growth of the mandible, but surely it can redirect the growth of the mandible. Stability of chin cup treatment remains unclear. Several investigators reported a tendency to return to original growth pattern after chin cup is discontinued. Next was the protection face mask therapy. As I mentioned, it is used in cases where the class 3 or skeletal anterior crossbite is due to the problem in maxilla, that is maxillary retrognathism. So we aim to protect the maxilla in a forward direction with the help of these face masks. So main objective of early treatment with face mask is to enhance forward displacement of maxilla by the sutural growth, and it is effective in primary, mixed and early permanent dentition. Function regulator can also be used to intercept the developing class 3. The appliance stretches the soft tissue envelope around the maxilla, stimulating its anterior growth, as well as preventing the mandible from growing any further anteriorly. These wire components are designed as in a manner so that it will enhance the growth of the maxilla in a forward direction, whereas it will inhibit the growth of the mandible, thereby trying to achieve the correction of anterior crossbite. The appliance is designed to restrict the forces of the associated soft tissue on the maxillary complex, transmitting these forces through the appliance to the mandible. Normally, 12 to 24 months are necessary to produce a response with the FR appliance. When used as a primary appliance, the FR3 is worn for about 20 hours a day, with the patient removing the appliance only during activities like eating and playing contact sports. Thank you for your patient hearing. I think these initial interceptive procedures we have taken. The remaining interceptive procedures we will discuss in the next video. Thank you.